and hopefully members can join us over the next few minutes before we really get into the meaty detail of the strategy. So Richard, could you pop the slides up, please, and then we'll make a start. So first of all, I'll introduce myself for those of you who I haven't met in person when I came to a session with you in the last year. So my name is Sarah Webster. I'm the ICB Director for Berkshire West, which is what we call the area that covers West Berkshire, Reading and Wokingham. So really pleased to be here. Thank you very much for your time this evening, where we're going to have a focused discussion and a listening event around our primary care strategy, which I know you've all looked at with great interest and have had some discussions amongst yourselves as well. So thank you very much for the engagement that you're giving to this strategy. Richard, could you just put it into slideshow mode if possible? Richard, I don't know if it's frozen on your, but there we go, perfect, thank you. I'm joined on our kind of ICB panel by Sanjay Desai and Abid Irfan, who I will let introduce themselves in a moment. I'll just do a little bit of housekeeping for this meeting as outlined on the next slide, Richard, if you wouldn't mind. So just a couple of bits, if you wouldn't mind keeping your microphone on mute if you're not speaking, just to help manage the background noise in the meeting. And if you can raise your virtual hand in Teams if you want to ask a question. We'll go through the presentation, then leave a lot of time for a Q&A session at the end. So please do just pop your hand up, or if you're having any technical issues, just wave at the screen and we'll see that you want to come in. That's no problem. And we can also take comments in the chat function if that's something you like to use as well. So we'll be keeping an eye on that and picking up any questions as we go. After the meeting, we will publish a recording of this, so there will be a record available for yourselves and for any members who weren't able to come along this evening. But do be aware that it will be posted in public after the meeting. And there's a questionnaire on the Your Voice portal, which we'd be really keen, if you haven't already done so, have a look at that and leave your feedback through that route as well. It's always really helpful to get that richness of direct feedback through the portal. So thank you very much. Obviously, we're here to talk about the primary care emerging strategy and get your views, and it's our chance to share a little bit more about the detail on that, and then have a good amount of time for question and answers. I will need to chair this quite robustly to make sure we finish at 8:30 this evening. We do need to close at that time. But if there are any questions that we don't manage to get through today, then absolutely follow up with us and through the feedback routes that we've got for the strategy. So on that note, I think I will hand over to Sanjay, if you could first introduce yourself and then start going through the slides, I think.
Sure. Yeah. Abid, do you want to go first? I want to introduce you and then I'll carry on. It's probably
Yeah. Hi. Good evening, everyone. So my name's Dr. Abid Irfan. I'm a GP, actually in Newbury, West Berkshire, and I'm Director of Primary Care for the Bob ICB.
Brilliant. So thank you, everyone. So I'm Sanjay Desai. I'm the Head of Primary Care Operations for Bob ICB, and it's really nice to be here to talk to you. To let you know, I'm a pharmacist by background. So I did train as a pharmacist and now I've moved into a slightly different role. And I will be talking to you for about 10 to 15 minutes about the primary care strategy. And then obviously time for questions after that. Can I have the next slide? Oh.
All right.
I think there's someone not on mute, actually. Are you able to go on mute, please, everyone? That's okay. Okay, so in terms of why do we need a strategy? So first of all, to tell you about the demographic details of Bob. We affectionately call ourselves Bob, but it's Buckinghamshire, Oxfordshire and Berkshire West, which makes up a population of about 2 million people. Within that, we've got 156 GP practices, 51 primary care networks, 203 dentists and about 250 pharmacies. So when we're talking about primary care, we are talking about all of these sectors, including optometrists as well. So GP practices, pharmacists, optometrists and dentists. So we're talking about the full shebang here. Why do we need a strategy? Well, we want to make sure that everyone who lives in Sorry. Anyone who lives in Bob should have the best possible start in life. They should live happier and have healthier lives as they live in our area. So we want to make sure that we can give the best possible care that we can in the patch. We know there's difficulties. We know there's some problems within primary care, and we're hoping that the strategy will help to address some of those issues that we know are there. And I'm sure we'll have some questions on that as we go through. Richard, next slide, please. So our in terms of what we're doing well, so if we want to celebrate the successes, first of all, we know when we look at certain GP practice data, there's many ways you can cut the data, but we know when we look at certain ones, we do fare well in terms of some of the quality measures compared to national averages. In addition to that, in addition to that, there was a service that's just rebranded called the Community Pharmacy Consultation Service, which is like a referral system from a GP practice to a community pharmacist. And we were like the second highest in the region, and we had a high uptake of referrals. In terms of us as a system, we have a strong focus on inequalities, prevention, and other factors which we feel are really important. In terms of population health management, we've got robust systems in place for us to be able to look at our data and see where we can base our care around how the data is formed. In terms of flexible dentistry, we are one of the first places in the country that we looked at our dental contract, and for about 10% of the dental contract, we allow the dentist to make sure that they look after the vulnerable patients or certain hard to reach groups. So to make sure that we can gear our dentistry and our dental activity around where it's needed. Also being a Bob-wide system, so being a larger system, we've got also the strength in doing things at scale. So we know that actually the larger we get, we know there are economies of scale to do certain parts of it. So again, that's some of the positives there. Next slide, please, Richard. And now come the challenges, and I'm sure these will resonate with a lot of you around there. So again, in certain data sets, we do see that patients are reporting back that they're having trouble accessing primary care. And we have seen in 2021 that there's 19% decrease in the positive responses with regard to how to book an appointment. The same thing also applies for dentists as well. We know that that patients in the patch and citizens are struggling to find a dentist in here as well. The Bob LMC, which is like the body that represents GP practice, have also said that actually staff are exhausted and they're under a lot of pressure. And this is sort of, happening across the board, really, in all of GP practices. They feel they're spending more time of doing administrative stuff than actually where they're seeing patients, and we need to make sure that we try and address that where possible. We use a line probably within the organisation, so we want clinicians to work at the top of their license. And what we mean by that is that we don't want to have GP practices, or GPs, I should say, doing the admin task. That needs to be pushed down to sort of other people that can do them just as well. In terms of pressures within dentistry, again, exactly the same as well. There is a capacity issue there in terms of recruitment, retention of dentists, and it's not meeting the demand that we do have. There is again, in terms of demand and capacity across the whole system for primary care, again, we know that the demand is more than what the capacity we have at present. In addition to that, we know that patients are now have multiple long-term conditions. Now, because they have multiple long-term conditions, it does mean that obviously they need more care, which means there's more demand on the system as well. In terms of sort of workforce aspects within community pharmacy as well, exactly the same. There were certain pharmacies that were open for 100 hours a week. So within a sort of a 1 week period, they were open for 100 hours. Earlier last year, I think it was, they were allowed to sort of reduce their hours down. And that's what allowed them to do that, because they cannot find pharmacists to man the pharmacies for the 100 hours there. Pharmacists or community pharmacists are also struggling to recruit both staff and locums as well. And I think some of that is because of the pressures, and also from where we live. We live in Bob, which is on the home counties as well, which we know it's an expensive part of the country to live. In terms of estates, we know we've got pressures with estates. Some of them aren't fit for purpose, some of them aren't big enough, and we need to look at that as part of our primary care strategy. Next slide, please, Richard. So in terms of our shared vision, we want to make sure that I'm going to literally just read this out because I think it spells it out quite well. Everyone in Bob has the support they need from primary care, working within a coordinated and integrated health and care system that supports people to stay well. And what we really want is for patients to be seen by the right professional the first time. What we wouldn't want to see is patients sort of going to one professional, then going to another, then going to another, and making sure that the professional they do see that first time is the right person. So for the more low complexity conditions, is it that they are referred to a community pharmacist? Is it but that they're seen by another professional in the GP practice, and therefore leaving the GPs to see the more complex patients that are out there as well. Next slide, please, Richard. Oops, sorry. So in terms of what we want to do, and as I said earlier, we want to make sure that people see the right support for the first time. So if patients are struggling to see GPs, we want to try and see if there's other professionals that can help to support that. We know when GP practices are overburdened, what that does mean is that patients, 10% of patients went to an A&E site to try and get an appointment. Now, can we ask you to go on mute, please? Okay. Yeah, thank you. Sorry. Yeah, lost my train of thought. Apologies. When patients can't see GP practices, we know they end up going to A&E actually because they want to have their condition. So in terms of what we want to, our future vision, it would be about giving patients the skills, giving them the resources, and where possible to self-manage themselves. So again, as I said, if it is those low complexity conditions, can they use the NHS 111 websites or whatever services they need? Can they self-treat themselves and give them the resources to be able to do that as well? If not, if they do need to see a GP, they phone up the GP practice, and we want to make sure that the care navigators, who are the people who take the phone calls, they navigate the phone, the call to the most appropriate professional who is in a GP practice. And again, there's a lot of work that's been done at the moment to try and get these care navigators trained up and making sure that they are diverting patients to the most appropriate clinician that's there. If a patient is made or they do have a contact, we want to make sure that it's the right contact based on the condition they've got. So be that the GP, the nurse, the physio, or is it that they're referred into one of the other sectors as well? Next slide, please, Richard. Now, if we can get this right and we can help that some of the low complexity patients are seen by the right people, we can therefore have other services to help serve those patients with more complex needs. This is about the personalised care agenda, and this will mean that we will have integrated neighbourhood teams, which is really all the professionals in that little circle that you can see on the screen, wrapped around the patient, with everyone working together, sharing information to help treat those patients, help treat the patient that's there. Now, every neighbourhood team will be slightly different depending on the need of the patient and the professionals that are needed there, but it does mean that actually we put the patient right in the centre of it, of the centre of care, and we wrap the care around them, making sure that everyone involved in the care works together seamlessly to get the best care for that patient. Next slide, please, Richard. So the other thing that we are really keen to see is the prevention agenda, because we know that by spending time on the prevention agenda, it means that we know that it's better outcomes for patients, and hopefully we can prevent them getting other conditions in the future. So we know that patients living in deprived conditions have 10 to 15 years poorer health than other patients. We know that 11% of our population are smokers. We know that 3 out of 5 people are overweight, and I sort of breathe in as I say that at the same time. We also know that nearly 18% don't undertake any physical activity. quality as well. So again, all of these attributes means that we need to make sure we focus in on prevention, and prevention is really key in order to save patients becoming worse or developing other conditions as well. Next slide, please. So there are 4 enablers to help us support this. One is workforce. So we need to definitely look at workforce to make sure that we can get the best use of the workforce we've got, but also support them in their roles when they're out there. So making sure, if we can, to give them coaching, give them mentoring, making sure that we can look at actually, is there job satisfaction in what they're doing? Could we also use some of our professionals to maybe do joint roles between us and the hospital sector within the patch? That way, giving more job satisfaction, but also helping to retain them in the system that we're in the Bob system. Looking at digital and data. So again, using digital and data means to help us drive some of our vision forward. For example, and I say this really cautiously with Kathy Mustill on the call, but with the NHS app, we want to make sure wherever possible we can try and use the NHS app, getting patients to use the NHS app, order their prescriptions, order their medicines, order their book their appointments. There's a lot of new functionality that keeps coming along with NHS app, and we need to make sure we get that information out to patients so that they're able to do that. Now, the other thing to say is that we will always make sure that we don't go to 100% NHS app type of software. There will always be the other routes, the more traditional routes of, visiting a pharmacy, visiting a GP practice, etc., where possible. In terms of estates, I've already alluded to before, we know that there's some work to be done on estates. And how can we work with our other system partners, local authorities, the acute trust, the hospitals, to see actually how can we look at all of our estates and see how we can use them to the best of the ability. In terms of resources, this is not just about money here. We want to... we also want to look at maybe, is there ways that we can change the location and change the type of work that people do? For instance, do we want to look at maybe getting people from the Royal Berks Hospital, some of the consultants, to come out and work within primary care as part of that multidisciplinary team, or running clinics within primary care as well? So it's about all resources. It's not just about money for that one. Next slide, please, Richard. So our priorities for delivery are the 3 that are listed there. So the first one is non-complex same-day care. Now, we are talking about the low complexity patients here. No low complex patients, and making sure that we can help serve them in the best possible way, directing them to the most appropriate professional and seeing the right professional for the first time. By doing that, we know that patients feel more valued and they know they'll get better use, but it also means that we can release the capacity for GPs to focus in on the more complex patients. Again, you all probably know this, but within a GP practice now, we haven't got just the traditional GP and nurse. We've now got pharmacists, we've got physios, we've got a whole range of professionals working there and making sure that the patient is directed to the most appropriate clinician, sorry. The second priority for us is integrated neighbourhood teams. So this, as I said earlier, is about, for those, again, more complex patients, to give them more personalised care and getting that wrap around with all the healthcare professionals that are important for that patient's conditions. Third one is a cardiovascular disease. Now, cardiovascular disease is one of our priority areas. And that's not to say that any other disease area is not important, but we're going to use cardiovascular disease because our data shows that this is an area that we need to focus in on. And we know that in terms of outcomes, we know that this has quite dramatic effects, and there's stuff we can do to help to support this. Once we've done cardiovascular disease, we've worked on it, we know how we've planned the work, we can then use the same methodology, tweak it and get it right for the other conditions as well. So this isn't to say we're only focusing on cardiovascular disease, it's the one that we're started off as an initial priority, and then obviously we'll move on after that. Next slide, please, Richard. Yep, so in terms of other improvements, as I've said, under general practice, we want to optimize the use of the NHS app wherever possible. We want to improve the ways that patients can contact and navigate their way through to GP practices. We want to we want to strengthen the primary care workforce and also the interaction between primary care and also our secondary care colleagues in the hospital as well. So making sure that there's a seamless care between the two. In terms of pharmacy, so as of the 31st of January, there's been a new launch of the new Pharmacy First initiative, and you've probably seen it all over the news and everywhere out there. It's the first time that pharmacists are now trained up to be able to treat 7 conditions, including things like ear infection, urinary tract infections, and as well as for instance, looking in your ear, pharmacists will also be able to treat you with the antibiotics as well, which is a first. Now, being a pharmacist, that's a really big move. I know previously when I used to work in community pharmacy, a patient would come in, they tell you their symptoms, and you had to say to them, look, I'm really sorry, you need antibiotics, you need to go to your doctors. Within half an hour, they go, well, maybe a bit longer than half an hour, go to their GP practice, come back with a script for an antibiotic, and you just think this is a real shame. So this is a new service that's been launched, as I said, from the 31st of January, and it means that patients can be seen the first time by the right professional. In terms of optometry, we wanted to implement an electronic referral platform, which means that if you go to your optometrist, your optician on the high street, if they find that you need to be referred into secondary care, rather than writing back to the GP, who then writes a referral letter off to the hospital, they can do that directly, which means that, again, it saves time and it means it's professional to professionals talking rather than adding an extra administrative burden on the GP practice. There'll be school eye testing as well, and that's going to be a national initiative to make sure that we can check children's eyes early. And again, if they need to have glasses, get them in, or whatever they need earlier on. In terms of dentistry, we want to further expand that flexible commissioning model within dentistry, and in terms of also the prevention agenda within dentistry, there will be more work around oral hygiene and dental hygiene within children, because we know that, and I think it's probably got worse during COVID. A lot of children are now suffering from bad teeth because they've not been checked. There's the implications of that. In terms of community, we want to make sure that we want to expand the hospital at home model, and making sure, again, getting patients to be treated at home where possible, but having the care around them, and improving the community services that we have in the patch. I think that might be my last slide, Richard. Yeah, brilliant. Thank you.
Thank you very much, Sanjay. So, Richard, should we take down the slides so that we can all see each other in slightly larger thumbnails? And what I'll do is, we've got just over half an hour left of the session, and I know that you had all come together and shared a number of questions in advance. I'm conscious we wouldn't be able to go through all of those questions in detail today, and so want to give you the chance to pull out the kind of the key areas for discussion today, and then we can feed the remainder of the questions into the engagement process we're going through at the moment. So really, I'd like to pause there, stop talking myself, and open up the floor to any particular comments from you all, and thank you again for spending the time engaging with us this evening.
Hello,
Douglas. Hi, good to see you, Doug. How are you doing?
Fine, thank you, Sarah. It's good to see you too. So a couple of questions very quickly. How aspirational is the strategy? Because it's very dependent on the primary care workforce. So how do we know that the primary care workforce is behind this?
Abid, do you want to take that one?
Yeah, I mean, the idea is that, Douglas, good to see you again. I haven't seen you for a while. You've got to build a resilience on the ground first. So we know that there's significant challenges out there. There's been a significant amount of investment through the additional roles reinvestment scheme. So a lot of resources come in, workforce has come in, as Sanjay's already outlined, to help GPs. I think there's a lot more we can do. So I think some of the building blocks are there, but we've got to take the steps slowly over the next couple of years. This is not a moment's work. This is going to take time to build. So we've got to make sure we've got the building blocks in place and expand on that. So yes, you could have a beautiful, ambitious strategy, but not be able to deliver on it. So we've got to have something that's kind of reasonable that we can actually deliver on. But there's still a lot of work Sanjay's rattled with quite a lot, but there's still quite a lot of work in here. So you're right, workforce recruitment retention is key, and it will be key, and we're absolutely cognizant of that.
Thank you. And I'll add that so our colleagues from across primary care have been involved in developing the strategy to this point. So clearly not every single GP has been involved, but representatives have, and they all have the opportunity to feedback, engage as well. So and that's replicated across the other pillars of primary care. So we're still very much in listening mode and shaping the final strategy, but it has been co-produced. Thank you. Jane. Oh, Jane, you're on mute.
I was hoping to hear that the GPs are supporting it and the other primary care providers, because certainly something has to change, and it seems like a very good comprehensive approach to getting change. There were a couple of little other points I wanted to make from my personal experience. One is Anima, which I think is working extremely well from a patient perspective. I've used it 3 times now, and I'm one of these people with complex long-term things, but it worked brilliantly. But from the GP's point of view, they get too much information, so they have to read more than is necessary. They really, I don't know if there's some way that the input information that the patient puts for 3/4 of it can be collapsed down so the GP can just spend 1 minute, not 3 minutes of the appointment reading the initial problem, the problem they're there for. And the other point is, again, from my experience, I got referred to a pulmonary rehabilitation course, exercise course last year, the end of last year, and it was brilliant. I was very negative about it going into it. I thought it couldn't possibly teach me anything, but it taught me a lot. It was really useful to have other people there with the same condition that we could exchange information with. And it's obviously additional funding to the normal things, but it's a perfect example of how to introduce exercise in a controlled way so that everybody could make use of it. I really encourage you to put that into the strategy and develop it further.
Thank you, Jane. Thank you. We welcome that positive feedback and noting the points around the Anima software in particular. And in terms of that approach of the kind of the pulmonary rehab service that you went through, and that ability to develop community networks and that sort of peer support, I think it's key to the kind of the self-care aim and element of this as well, is how do we step up as communities to support one another for things that don't necessarily need an overly medicalized approach, obviously within the right parameters and clinical plans that we've got. So really pleased to hear your positive feedback on that. Thank you.
I have one quick other thing. I saw some newspaper thing about a project so that all medical care notes can be made available to everybody across the medical care provision and the patient themselves. I thought that already happened, does it not?
Abid, did you want to?
So, not strictly speaking, no, no. A lot of patients think that it happens, but we have a system called connected care. So in primary care, we have access to kind of local authority, social services, secondary care. All that data is integrated, so I can click on a button in my practice on my system and see what's going on. But if you went into the acute hospital, you wouldn't necessarily be able to see the GP notes, if you see what I mean. So if you go in to have an operation or you go in as an emergency, there's bits you can see through something called GP Connect. So you could maybe be able to see a summary like medicines and high level, but the detail you may not. But I saw that. I think I saw the same article that you're referring to. So I think there's a project that's theoretically going to do the whole lot and bring everything and connect everything. I mean, that's a huge project. It'd be great if they can do it.
Thank you, Jane. I'll go to Barry next.
Yes, hello, Barry Dickens from Chapel Row Surgery. Actually links on to Jane's point. I was somewhat surprised in the presentation on the strategy that at no time was any mention made of IT systems, which will have to underpin the whole delivery of the strategy, and the work and budget that needs to be found to make sure that the strategy doesn't fail as a result of IT lack of interconnectivity and transfer, cross-fertilization of clinical data.
Sanjay, did you want to touch on that one?
Yeah, I mean, sorry, Barry, I'll probably, if you read the bigger document, there's more detail in some of that, but I think you're right. IT is an absolute must, and we need to make sure that it is right. And I think that interconnectivity between the different professionals is absolutely right. The NHS is very, very tight in terms of information governance, actually, in terms of sharing information between different professionals, and even within the system, it's very, very tight. So, I'd agree with you, and I think this is something that obviously once we launch the final strategy, obviously we will see about what the budgets are, see what we need to do, and obviously focusing our energies on where that's done.
Thank you.
Thanks, Sanjay, and thanks, Barry. Tom, I'll come to you next.
Oh, thank you. Sorry, trying to unmute. We read that the Bob area had been third most severe cut to GP funding nationally over the 3 years from 2018, and so they said there was an 11.2% cut according to the House of Commons Library or something. So we wondered, firstly, have you got mechanisms to flexibly pay GP practices, because after all some of the funding is by national scales and so on, and then have you got those mechanisms, and will there be budget to at least sort of claw back some of those cuts that happened?
Abid, do you want to start on that, and then I'll come in?
Yeah, Tom, I think it's so we've had a considerable amount of expansion. There's probably a number of reasons to why where the budget has been reduced. There's been no cuts, first of all, so nobody's cut anything. As you rightly pointed out, there's a national budget, it comes through to the ICB, but sometimes there's a lag between significant population growth, which we've had across our patch, and the money that comes through. Just the way the mechanism is done, there's probably a 6-9 month lag there, and we know there's been a lot of growth. So I think that's one reason. The other reason is we're nationally we're probably underfunded by a certain percentage, and that gets adjusted every year. But it's the way the NHS does it. It's quite a slow process, so that doesn't help. So compared to some parts of the country, we're probably below, off target, as they say, and it takes time to build that up. So what we can do, I think, going forward, I understand from the executive team that primary care is probably the only area where there will be some growth money this next year. So there is you could look at it as, and compared to secondary, where it'll be flat cash, so they'll have no growth. So they've got to live in that same budget they had this year. So I think you could look at it as kind of national team trying to move resource. But yes, we'll do what we can, obviously, to kind of differentially invest, or what flexibility we have to make sure we can deliver these plans and look at resourcing. But the detail of that we need to get into. I haven't got a fully worked up answer as to how that might work, but that'll be some of the work we do over the next couple of months.
Thanks, Abid. I think there's also a big element of this, which is around sort of aligning teams, aligning resourcing that we've already got in place that perhaps just isn't being deployed in the most efficient way because of the issues that were very clearly articulated in the presentation. So it's not necessarily always going to be about more, it's about how we're probably better using what we've currently got with digital enablers that will make things hopefully easier in the future as well. So, Tom, you're back on mute.
Sorry, at the partnership meeting, Rachel Decaux said there was no money at all for estates, and that's very disappointing, because we do have some lagging practices, and estates is one of their problems, and some really old-fashioned sort of small urban practices. So is that really the case, and can we look forward to any expansion, any money, any improvement for estates?
I think she said there was I think what she said was the ICB doesn't have capital, and that is the case. It has been for the last couple of years, but there are other ways, and I think the strategy kind of alludes to looking at the one public estate and being smarter about how we use void space in the system. It could be local authority, it could be community trust. There may be other pockets, and we've got to be a bit smarter with that. And but there are other mechanisms. You know, if you've got a good developer or a third-party developer, perhaps Section 106 funding and so forth, there are other mechanisms you could, which I know practices have done so, to kind of use that and build new premises. But yeah, there is no, we don't hold capital at this stage. We haven't got, you know, we haven't got that. So it is a bit slightly constrained there.
Thank you, Abid. I'll move on next to Catherine.
Oh, hello, I'm unmuted. Sanjay, thank you for an excellent summary. Had I heard your summary today, I wouldn't have had to spend all day reading. So I just have 3 points, and it's not about the strategy, because the strategy is the start of the documentation, and whatever plans you do, you have to have a strategy before you get to plans. For me, there are 3 key points. The way primary care is going to work is about changing the way staff are working, well, patients as well, how they react to, and there must be a big section of how to train staff. You know, from the receptionist to everybody, you know, it's a different way of working for everybody. You can't get away from that. That's the first thing. The second thing is of course in there, by training, I also mean, how do we get hold of the public? How do we latch onto them to say, okay, you guys, you can have your healthcare, but you've got to do things a little bit different, you know, because we are so used to in the NHS, well, in England, that everybody looks after you, that you forget that you have a responsibility to look after yourself as well. And I'm not saying when you're very ill or whatever the case is, but, you know, kind of, you know what I mean, like minor things. That's the second thing is. And finally, well, in that there's some digital elements, because it's the digital of the community, of the systems and the apps and everything. I mean, digital changes every day, and it's not easy, especially if you don't use it all the time. And finally, is communications. There must be a big key element of communications. I could see the comms team. There's 2 people from the comms team on the call, but it's the comms to the wider sector of the ICB, to the patients, to the providers, to the staff, the different ways of communications. And I know we always talk about communications and all the things of how we're going to communicate, Twitter and all those kind of things. But actually, I'm not sure. I don't know what the answer is. I mean, I've come to the conclusion now that if you wanted to communicate with me and if I wanted to know the latest news, I'd have to go and stand in line at the supermarket with my ears wigging, and I would hear it all. That's all from me. So those are my 3 points, that as we get to, as you, well, not me, you guys, because I'm not there anymore, is when you know, when you start deploying that, those are the key things to make it successful for people like me on the other side of the fence. That's all from me.
No, thank you, Catherine. There's 3 really, really important points there. I don't know, Sanjay, did you want to pull out any of those? I think Catherine made the points really, really well, actually.
Yeah, no, and I think Catherine and I used to work together, everyone. So just to declare that interest there in the ICB and CCGs. And I think, Catherine, you're absolutely right. I think communication is key to this, and it's communication with staff, exactly as you said. And as I talked about the care navigators, again, there's a lot of training gone into care navigation to make sure that staff are properly trained in order to triage, to navigate those patients to the right professional. And I think you're absolutely right. So around patients, and again, I don't like talking about NHS app with you on the screen, but NHS app is one that we need to get our comms right and need to, you know, really get that messaging. And Sally Moore from our comms team who's on the call, we've spoke about this, but and I think the plea would be also to you guys as PPG chairs, if there's anything you can support us with in terms of getting that communications out to patients, we'd really support that, because I think it is right. We need to make sure we tailor the communications in the right way to patients. Now, if it is all these fangly Instagram, you know, hot, whatever, I don't know what the new things are, actually. You have to ask Sarah, being a youngster, but you know, the TikToks of the world. But we need to think about how we use social media appropriately to get the message out to those right groups of people. I can just picture now Sarah doing a TikTok video on NHS app, and that would be brilliant, but I'm not sure that would work.
But please don't note that down as an official action from this session. I don't think anyone would be thanking us for that. Thank you very much, Catherine. So I'll go on to David next.
Hi. Yeah, can I follow on Catherine's point, actually, because communication is about building relationships and trust, which will be very important. And one area that was of concern to our group was the level of confidentiality and how that would be preserved when you're moving patients over to new professional groups, particularly pharmacists, because when I go into my pharmacy in Christchurch Road, which is my local pharmacy, I have a queue of about 6 people waiting to be served and about 4 people waiting to get their prescription. And so a woman will come in with some really quite important confidential issue about her person. And I'm not sure where the pharmacies, especially if they're short of staff, are trained or will be trained to handle those confidential issues, which are going to be very crucial for a large section of the population. I hope you can give me some assurance on that.
Yeah. Shall I come in, Sarah? That's good.
Yeah.
I mean, pharmacists are trained to deal with confidentiality. Every pharmacy has a consultation booth. That came in when the new pharmacy contract came out back in, 2005, I think it was. So they all have consultation booths. And if you go into your pharmacy and ask the pharmacist, could I speak to you in the consultation booth? They are there for that reason. And the reason that they brought that in is because they knew that new services would be coming on board as part of the contract. And it meant that these services can be then provided in that specific space. So in terms of the Pharmacy First that I mentioned earlier on, again, they will be doing those consultations within the consultation booth, and that's what the booths have been set up for.
Can I just add on that? How would that happen with this new method of triaging with the navigators? Will they have that same training?
So the care navigators are staff that are in the GP practices, and they will then navigate the patient to the right professional.
And they will all have the same confidentiality agreement as everybody else.
Yeah.
Oh, absolutely. Yeah, they work in the GP practices already, actually. So yes.
Okay. Yeah. Okay. Thank you.
Thank you, David. Really, really, really important points there. Joan, I'll come to you next. Oh, Joan, you're still on mute. There we go.
Can you hear me?
Yep. Yeah, we can hear you.
The chap that came in earlier on about IT and the availability of information, it's being worked on, but on NHS Futures, if you go online and dial up NHS Futures, it will show you all the work that's being done on the IT systems. And it will give you like various task bars where you can pick up all the ICSs. And if you click on your one, you can find all the attributes and the illness profiles in total of your entire population. I've done a course on it. So if you can just remember, NHS Futures is the answer to that one. It's not actually incorporated yet, because the seminar I went to was about the taskbar and the design of it and all the people working on the content and what all the nitty gritty of the taskbar is, the information it will give you if you click on it. So, I mean, it's actually quite smart. And also, I was worried about all the money being spent and all these grand ideas, and I'm still waiting. And I've kind of got a grievance about that. I think basically, if someone's made you wait 20 odd years for something, when they promised you 2, they should put their shoulder to the wheel and make sure that your needs are dealt with first. But what you're all doing is putting you first and what you want first and making it all smart and pushing everyone out onto the perimeters so that we still can't get anything. And to me, that is a broken model still. It's not working. And it won't ever work, because the actual focus should be the patient, not this bit of communication or that bit of staff or whatever else, and getting yourselves in first and knowing that you never ever have to justify the first because you've made us all last. I mean, it's disgusting. I think it's awful. And I'm still complaining. So please note, try and get it right. I don't want to have to go to meeting after meeting with all these people there and voice my opinion, because I can be, well, I can be pretty grouchy, you know, and I can get to the point. And I'm not asking you, I'm absolutely begging you to get it right. And don't make me complain again, because I'm getting really good at it. So that's what I've got.
Thank you, Joan. And sorry to hear that you've had sort of cause for complaint, and that some of the issues that we know are present in the system have clearly affected you personally.
Well,
and if there's anything that we want to kind of take forward separately outside of this meeting, then we absolutely can
you
do.
send me a complaint form, please, Sarah. I'd be so
Yeah,
grateful.
we can send you the contact
My
details,
email
absolutely the
box,
details for that.
Fill it out and I'll send it back. Okay.
Yeah,
I'm
we can arrange for
absolutely-
that. I think what I would say is we're really hoping that.
Wow. And also all this sharing of information, somebody mentioned earlier, David. I mean, it makes you sick. You go in the pharmacy, you've got to get a prescription, and the pharmacist is shouting in your face and trying to humiliate you in front of a, you know, a pharmacy full of people, you know, making you confirm your name, your address, your postcode, and all that personal information. And I complained about it. I said, you've got no right to ask me to verify everything when you, I mean, they know me, they've seen me before. You know, it's not rocket science. Why do you have to own the question and give my information to sort of 10 people in the shop? It's a disgrace.
So I think so on that there are some processes that we have to go through from a kind of a diligence perspective, but there's ways of doing that that should feel more comfortable for you on the receiving end. So again, that's something I'd encourage you to raise sort of with the pharmacies you have done, or with us through the route that I'll share after the meeting. What I would say kind of in summary is we do hope that the strategy that we're engaging on at the moment, that we're here talking about, moves away from having sort of siloed services to, exactly as Sanjay described, wrapping services around the person. So the needs of the person comes first.
I've run out of pharmacies to swap to. So, I mean, can you make it fast? Do you know, solving that problem?
Yeah, we'll do this. This is a high priority that will be looked at as quickly as we can. But as Abid said, there's a lot to work through in terms of how to make this a reality and how to do it in a way that doesn't destabilise. So,
I mean, I'm sick of it. Can you get it right? Do you know, what does it take? Yeah. I'm going to go on to the Houses of Parliament and stand there with my placard. You know.
Okay. Well, thank you for sharing that and your experiences, and apologies again. I think we're all committed to trying to do the absolute best with this. And if there's any other specific feedback you've got, then please do share it through, and I will share the details for our complaints team as well. Thank you, Joan. I will move us on and to make sure we capture views from everybody. So Francis, I'll bring you in next.
Yes, hello. I'd like to link together three things: national productivity, the cost of the NHS, and physiotherapy, which is not mentioned once, I think, in this report. Now, clearly, you know, we talk about national productivity, all the parties talk about it, it is fundamental, and yet the NHS needs funding, it only can come from productivity, and yet I'm concerned that physio isn't mentioned at all. That's the point I'd like to make. There are other points I'd like to make, but we've spent a lot of time on other things. I'll come back after others for a different topic. So there it is, physio, please.
Thank you, Francis. So I suppose the core of the strategy is around primary care, of which physiotherapy isn't kind of one of those core attributes. However, having said that, when we're looking at the different roles and different kind of professional inputs into your current general practice model, physiotherapy absolutely is part of that. Abid might want to expand on this. So it's very much something where it's one of those services where, again, Sanjay spoke about the eliminating the GP from being the middleman between an optometrist and secondary care. Similarly, a lot of work has gone into how do we make sure that patients can have direct access to physiotherapists without needing to go through other hurdles to get there as well. So if it's not explicit in the strategy, and we'll make a note of that to make and your feedback, it very much is part of that sort of well-rounded holistic team that we'd want to establish within neighbourhoods. Abid, is there anything you'd want to add on that?
I think you've covered it, Sarah. Yeah, I mean, you're right, Francis. I mean, physiotherapy, physiotherapists, very important, and they're part of that additional roles, as Sarah's outlined. So a lot of practices, you can go directly to a specialist physiotherapist, a highly qualified one. So Band 7, we're talking about. And as Sarah's outlined, one of the things we have been working on is for patient ease is direct. You can refer yourself directly. So Berkshire Healthcare Foundation Trust, now you can go on their website, have a look. Maybe when you're logged off here tonight, you can self-refer, so you don't even need to come and see a GP anymore if you want. You feel need physiotherapy, they'll go through the questions and they can manage that. So that's the big new thing. So you can either come in and you get directed, or you can self-refer. That makes it easier, much easier. Yeah.
Thank you. I'll move to Imogen now.
Yeah, thank you so much. I mean, it's really exciting, this kind of patient-focused care where they're kind of more focused on looking after themselves. The main problem I had was just, we've recently done a lot of research about people uptaking the NHS app and also the new system with kind of care navigators, and a lot of people not actually being aware of the new systems, which has caused like a kind of a lack of trust and also a bit of confusion. You briefly mentioned the kind of the comm side of it and made a little joke about the TikTok, but it kind of, in terms of like legitimately doing comms differently from the NHS app to make sure the uptake is trusted and actually works, kind of what is the comm strategy? How is it going to be different from kind of what happened last time?
So I think the common strategy is evolving and developing, and once we've finished the kind of listening engagement exercise linked to the strategy, clearly there'll be, first of all, that kind of blanket approach to share this is what we're all about, but then for each individual strand of that, such as kind of the NHS app, we'll need to be very clear around how we are engaging, promoting, and upskilling where needed our residents who want to be able to use that route. So I'd say that at the moment that's still under development. I'm working with organisations such as Healthwatch and these groups and other community groups and ways to kind of reach everybody that we can do. I think it's going to be really important as part of that.
So can I just come in actually? So
yes,
again, Imogen, I met with Alice this week from Healthwatch, and again, she's fed us back. She's given us some good feedback around communication. So again, as we've been doing these strategy engagement events, we've absolutely taken the message about communication and making sure we communicate in the right way. And that's why, again, the plea to you guys as PPGs and Healthwatch, any suggestions on how we can get that messaging, we'd really appreciate it, because we want to get the messaging right, and we've got to use whichever means suits the population in the right way.
Thank you. I'm probably going to take our final couple of questions now, conscious of time, and then we'll wrap up. So I'll go to Paul and then Tom. So Paul.
Hi, thank you very much. It's been a very interesting discussion. My point is around PPGs. Successful surgeries, practices have good PPGs. The ones who are underperforming don't have PPGs. And I'm aware contractually for many years, they should have had PPGs. So what are you going to do to facilitate underperforming surgeries to start to have PPGs so that they can get feedback about communications, strategy, and all these things where they could make a genuine contribution to the way forward?
Thank you, Paul. That's a good question. Abid, do you want to come in on that one?
Yeah, I mean, practices simply should have PPGs. Like you said, an active community that's representative of all the patients, to inform strategy and get involved with initiatives and so forth. So, did you say you've got some specific examples where they haven't? They've got nothing?
Yes, there are plenty in South Reading to do that. So, I mean, and that the University Medical Centre is a good example of a successful community, but there are many which don't. and I don't think I should actually list them all for you
No.
at the moment,
No.
but you must be aware, you contractually, they're meant to have them. They must be saying to you, if they're receiving the payments, that they've got one, but they don't exist. We know that.
I think that's something, Sanjay, we can certainly take away and look at and just cross-check from our end. Yeah, we'll pick that up. Thank you, Paul. Yeah, I agree with you.
Thank you.
Okay, I will
And
write
then,
to you to give
thank
you
you,
the
Paul. I
list.
think that'd be helpful.
Yeah, that'd be helpful. Thank you.
I'm going to go to Tom for the final question. Apologies, Joan, but I think we're going to run out of time in a second. So if there's further feedback you want to give us, then please do either write directly or use the engagement route. So Tom, I'll leave you the last question.
Okay, so just a couple of comments first. Patients have very little idea of where they can self-refer. There's a number of services, but they don't know what they are. And then another thing about people who are looked after at home by multidisciplinary teams. Often these are people who have difficulty getting out, they might be quite frail and so on. But if you talk to them, it really is important to talk to them, I think. You find that there's a lot of confusion. Oh, so-and-so was supposed to come and take bloods. Oh, it's been weeks, we haven't got the blood test. Oh, you have to come to the surgery. And it's a lot of confusion, and it really needs to be much smoother and much better coordinated, I think. I mean, I do your own research, but that's when I talk to some people, and that you do hear that things are not working, it's not coordinated properly. Now, the question I really wanted to ask was about clinical standards in this much more spread out form of primary care, because you do in your we don't see it, but in your practices, you're doing clinical audit and discussions about patients, and we just wonder how the clinical assurance and the audit and all that will work when patients are going to pharmacists and going off to physios and all that, and a much broader sort of system. How will the clinical assurance really work?
Thank you, Tom. That's a good question. Abid, I see you want to come in.
I mean, Tom, you're right. I mean, patients are going to be assured that the additional different staff who are seeing them, you know, they're getting not only seen quickly, good access and so forth, but they're getting the right level of care. So certainly I can tell you how it works in my practice. We have 4 physicians associates. As an example, we have other allied healthcare professionals, but let's just take the physicians associates. We're a large training practice. So we have debriefing sessions with those physicians associates once they've done their morning clinic or afternoon clinic, and we go through each individual patient. So if it's straightforward, we'll have a look through the notes and, you know, it's covered off. But if there's something more complex, we'll discuss each case with them, no matter whether they're year 1 or whether they're year 4 trained. So we do that every day. So a partner has oversight, and other practices will do the same for let's say if there's a physiotherapist practitioner or a paramedic, cases are reviewed and so forth. So that is good clinical governance, and that's what should be happening in practices, and with proper oversight, because a lot of these people are not doctors, so they are there to assist the GPs to do their work, and there should be 100% oversight. So and then there will be regulation as well for a lot of these health professionals as well. That's the other thing. They will, if they're not regulated now, they will be regulated with their own professional bodies.
I think,
Sarah, can I just comment about pharmacies?
Yes.
And again, community pharmacists are the same. They're professionals in their own right. They would have gone through rigorous training. In terms of the new services that are being provided, it's within a framework. So there's what's known as a patient group direction, which is almost a protocol by which pharmacists can only give out medicines under set criteria. And if the patients don't fit that criteria, they're not able to prescribe it. So it's not a free-for-all that they can do anyone. There is absolute tight criterion in terms of what they're allowed to do and what they can't do.
Thank you very much, and thank you for your questions.
Sarah,
we have
can we
overrun,
just thank
so
people in the chat? There's quite a few questions coming out. Obviously, we won't have time to answer them. Just thank people for putting them. Abid, you answered one, but there's some information asking. We haven't got time now, Sarah, but we do appreciate the people putting those chats in, and just to remind people to take part in our survey, you know, on our engagement platform. That would be really helpful. Thank you very much.
Yeah, thank you. And where we've not been able to answer the questions in the chat, we will come back to those as part of the process we're going through at the moment on the strategy. And if there are any further questions or feedback or suggestions, please do use the routes that we've explained to be able to provide that further feedback. So on that note, thank you so much for your time this evening. Sorry that we haven't been able to get to all of the questions, but it's been a really, really rich discussion, and we really value your input, and look forward to continuing to talk to you about this over the coming months as we move from